So our first speaker is Dr. Helena Hansen. She's a professor and chair, the research theme in translational social science and health equity at the David Geffen School of Medicine at UCLA. She got an MD and a PhD in cultural anthropology at Yale University. While in grad school, she did fieldwork in Havana on Cuban AIDS policy and in Puerto Rico on faith healing. And she does a lot of work on addiction and media portrayals of addiction. And that's what I've asked her to come talk about today. So she's going to talk about how the media have covered addiction over the years, depending on which demographic group is most tied up in that particular addiction. And she'll talk about some of the equity, racial equity, dealing with addiction. So Dr. Hansen, I want to thank you very much for coming, and I'll turn it over to you.
Thank you so much. I want to thank you, Chris Adams, and the National Press Foundation for the honor of speaking with you today. So this is actually the title of my forthcoming book, which is based on a decade's worth of research on the intersection of race with the opioid crisis and the growing field of addiction medicine, which I'm sure you're learning a lot about from this ISAM meeting. ISAM represents a big engine for the training and production of addiction physicians and other practitioners focused on addiction. So I started the study at a time when the media was publishing stories about the surprise of white suburban and rural opioid addiction. And since that time, unfortunately, the plot has only thickened. So overdose deaths in the US have increased more than 40% since the onset of COVID. And the overdose rate has gone up the fastest among Black residents in Western and Southern states, with Black people in California, for example, overdosing at 30% more often than white people in California. So our overdose policy response will now even be more clearly framed as a racial justice issue. You know, I just want to put that on the table. You're going to see a lot more about overdose policy and response as a racial justice issue as opposed to something that affects white Americans. But of course, what makes the overdose crisis of the past 20 years different in people's minds is the way that the white identity of sufferers has been highlighted in media and in public policy. So today I'm going to talk about my approach to race and health from an angle that's unusual in medicine. I'm going to look at the mechanisms of whiteness of the opioid crisis. I'm going to share a case study of the hidden but active maintenance of white exclusivity in medicine as the cause of what we often call health disparities among underserved minorities, kind of in a passive manner, so groups that lack access to care. What we don't look at as closely is how whiteness is central to our environment of profit motives, commodification, and the use of racial hierarchies to segment and open markets. And I'll just give you one image to convey that. So it involves the mutual racialization of drugs and people. Drugs can be white, as in targeted to white clientele. They can pharmaceutically enhance the whiteness of people whose privilege is in question because of stigmatizing diagnoses like addiction. So I first encountered office-based medication for opioid dependence in the late 90s as a medical student. I was working on the early clinical trials of buprenorphine, otherwise known as Suboxone. And my attendings were excited about buprenorphine, which they said was about to change the culture of medicine. Defining addiction as a chronic disease treatable alongside diabetes, hypertension, and asthma in the same clinics, in the same way, with pharmaceutical maintenance. And so I just want to highlight that this was a big change in the way that addiction was seen, even among physicians. And at the ASAM meeting, you're going to be hearing a lot about addiction as a brain disease. And I just want to flag that that's a relatively new cultural development, actually, over the past couple of decades. So this caught my ear as an MD PhD student, cross-training in cultural anthropology, and I had to ask, what could it mean to change the culture of medicine? You know, the ways that my professors were talking about it. What would drive this change? And as it turns out, my attendings were right. In the course of my career in addiction psychiatry, I've witnessed a profound change in the ways that we as doctors frame addiction. My field of addiction treatment swang from drug-free philosophy in the early 90s, meaning, the problem is substance use, so try to get people away from using any type of substance. They swang from that to opioid maintenance as first line of treatment and by the 2000s with buprenorphine primarily, and also methadone. As I completed an addiction fellowship and took a faculty position in psychiatry and anthropology, I documented stark differences between buprenorphine patients and methadone patients by race and class. So what began as a study of the culture of medicine became a study of how the opioid crisis came to be seen as white. Ironically, at the same time that racially targeted drug war policies were leading to mass incarceration of Black and Latinx Americans, giving the US the highest incarceration rate in the world. And I'll show you that slide in a moment. But I'm going to give you an analysis from my forthcoming book, and this was based on research supported by the National Institute on Drug Abuse, Robert Wood Johnson Foundation, American Psychiatric Association, and the New York State Department of Health. So in a departure from this image, I want to highlight that in the US, narcotics have long been criminalized through association with marginalized racial groups. Such as turn-of-the-century images of Chinese opium dens and Negro cocaine fiends in the South and Mexican marijuana madness. So these were images that helped to build support for prohibitionist policies in the early 20th century, and they continued through the 20th century to do so. But we don't often look at how symbolic associations with white middle-class markets has all along legitimated widespread use of prescription narcotics, including post-World War II epidemic overdose from barbiturates and benzodiazepines that haunted white middle-class America. So this is actually not the first white middle-class or white in general overdose crisis that we've seen in this country. I just want to highlight that. But we rarely ask in public how a drug can assume whiteness within a pharmaceutical logic based on race. At the same time, that is the question that is at the core of the widely asked question of why the life expectancy of whites is suddenly falling while the life expectancy of almost every other racial group is rising. So this is a headline from the article that came out in 2015, just before the national election in which Trump won the presidency. And it reported on this unique finding that white Americans had fallen in life expectancy over the last couple of decades by 5 years, whereas almost every other racial ethnic group other than Native Americans, the life expectancy had risen. And also the question is, how did overdose become the primary immediate cause of excess death here? So I want to go beyond the received wisdom that unemployed white people in the post-industrial Rust Belt have turned to opioids for solace. So that may be true, but it begs the question of why opioids, why white people, and why now? And so I'm going to argue that the current generation of opioids were designed to have white racial identities, and that in our stratified healthcare and justice systems, the social technologies shaping opioid consumption reinforce racial inequalities, while at the same time harming white Americans. So key to this story is an unrecognized form of ethnic marketing that, because it targets white people, works by not marking itself as racial. So the story is invisible by design, and it's only been through years of my observation and interviews with key actors and those of my coworkers, my colleagues in this research, that I've been able to unravel the threads. So I've observed drug policy and addiction science meetings and clinical interactions over a 10-year period, and interviewed almost 200 addiction scientists, treatment advocates, pharmaceutical executives, policymakers, administrators, prescribers, and patients. And I'm going to start where I started the study, which is with Suboxone or buprenorphine. It's easiest to see its racial identity by comparing it to its predecessor, methadone. So here's a bar graph from the first and last nationally representative study to compare buprenorphine patients to methadone patients by race and class. It was not the last representative study, because its findings were essentially confirmed 15 years later by this study that came out in JAMA Psychiatry 2019 that found that white Americans who had opioid use disorder were 3 to 4 times as likely as Black Americans to get a buprenorphine prescription. And so this is a longstanding pattern that you're going to hear a lot about, I think, at this ASAM meeting under the rubric of inequalities in addiction treatment. But what we don't know from slides like this and graphs like this is by what process did buprenorphine and methadone gain their racial identities? So for that, let's go back in time. Let's start in 1965. Race riots have burned through Harlem, Philadelphia, and Watts, Los Angeles. The unemployment rate for Black Americans is twice that of white Americans. And organized crime gains control of Asian heroin imports, recruiting a sales force from Black and Latinx inner cities. And meanwhile, Rockefeller University metabolic researcher Vincent Dole, who thinks of heroin addiction as opiate receptor deficiency, analogous to insulin deficiency in diabetes, he publishes findings from the first clinical trial of methadone maintenance. And the study's subjects are African-American heroin-injecting men from Harlem. Its outcomes of reduced criminal activity, arrest, really, and increased employment at 6 months brings it national attention. So by 1970, news of methadone as a pharmacological answer to urban heroin reaches President Nixon, who appoints pioneering methadone psychiatrist Jerome Jaffe as the nation's first drug czar. Nixon targets inner city Black and Latinx Americans, as well as returning Vietnam veterans with methadone, which he dubs the major weapon in his war on drugs. And to prevent diversion and street sale of methadone, the DEA regulates methadone clinics directly, requiring daily observed dosing and regular urine testing. Due to community resistance, the clinics are located in marginalized neighborhoods in the city, remote from other medical services. So methadone has long had this only quasi-medical status, also a quasi-criminalized status in that sense. So let's fast forward to October 8th, 2002. A new kind of opioid problem has developed following Purdue Pharmaceuticals' aggressive marketing of OxyContin as a quote unquote minimally addictive pain reliever. And most of these newly dependent people are white, many of them are middle to upper income. The FDA has just approved the synthetic opiate buprenorphine, commercially packaged with naloxone as Suboxone for maintenance treatment of opiate dependence in buprenorphine certified doctors' offices. Pharmacologically similar to methadone in that it blocks opiate receptors in the brains of addicted patients, buprenorphine can be prescribed monthly for use at home, while methadone is still restricted to DEA-regulated clinics with directly observed dosing. Office-based buprenorphine represents a reversal of national policy. It's the first time since the 1914 Harrison Act, so 80 years, that private doctors are permitted to use opioids to treat opiate dependence. And to accomplish this, the manufacturers of buprenorphine and the architects of buprenorphine policy had to distinguish buprenorphine symbolically and spatially from methadone. So buprenorphine, pharmacologically in the same drug class as methadone, had to be whitened. To illustrate this, I just want to show this image. This is Mike. He's in an internet ad for Suboxone. He's seated in his Ohio diner. He's flanked by American flags. You can't quite, yeah, you can see that in the bottom image. He's talking about returning to coaching his son's baseball team and singing in his church choir after buprenorphine rescued him from a prescription opioid habit following a back injury. So, you know, the ad itself is replete with a lot of imagery around who is the addicted person that flies in the face of the racial imagery of the American addict. So it's American apple pie, essentially. But I argue that the ad was just the tip of the iceberg, that the whiteness of buprenorphine was actively achieved by specific social technologies. So I'm going to give you an analysis of the contemporary white opioid crisis in terms of what I call technologies of whiteness. And that is social technologies of neuroscientific metaphors, policy, and industry strategies that maintain racial boundaries around biomedical uses of opioids. And this scheme is informed by whiteness studies, which is an offshoot of critical race theory. And it proposes that one, whiteness is a category of exclusion. You know, in the US, not everyone can claim to be white. It's actually something that is an exclusive category and requires cultural and political maintenance of its boundaries. let me just go through this list. 2, white race is unmarked. It's the assumed norm in the US. And prior to the last presidential administration, it was rarely explicitly named, either in public policies or in the media. And so I think that the last 4 years is actually the exception that proves the rule. I'm going to talk a little bit later about a media content analysis I did of coverage of opioids. But essentially, the idea is that in our society, in the media, you can find evidence of this in media coverage. When race is mentioned, it's usually not white race. And there have been some exceptions lately, as the status of white Americans itself has kind of been called into question in politics. I also want to highlight another way that race is often erased, which is, for example, Michelle Alexander, author of The New Jim Crow about mass incarceration and race in the United States. She uses the term colorblind ideology to call attention to the fact that race can be it can be eliminated from policy decisions and public policies that do actually have explicit racial intent. So, for example, the 1986 Anti-Drug Abuse Act that mandated mandatory minimum sentencing for 1/100th the weight of crack cocaine as opposed to powder cocaine in an era in which crack cocaine was being represented in the media as a black and brown drug and powder cocaine a white affluent person's drug. That's one example of a policy where race is never mentioned, but there's a clear racial intent. Then third, whiteness is defined by its other. So white on the one hand and black or non-white on the other hand are interdependent. And punitive American drug policy has long had a mutually defining twin of legal narcotics for white people who have access to personal doctors, starting with morphine and over-the-counter heroin for middle-class Victorian housewives, then moving to post-World War II barbiturates, as I flagged earlier, stimulant diet pills, Valium, otherwise known as suburban mother's little helper, and now back to prescription opioid pain relievers in the last 20 years. And then lastly, white privilege has its costs. Not only do white consumers pay inflated prices for patented prescription opioids, but they also pay with their lives in overdose by lethal substances to which they have privileged access. And so I'm going to talk about 4 technologies of whiteness, and I'll go through those one by one. I'm going to start with the least visible technology of race making, which is brain science. We have to place buprenorphine development on the backdrop of President Bush, the first decade of the brain. And this was an era in which NIDA was directed to look for neuromolecular bases for addiction in anticipation of breakthroughs from the Human Genome Project. In the process, NIDA, National Institute on Drug Abuse, renamed addiction a chronic relapsing brain disease. And this was supported by leading NIDA researchers who co-authored this widely cited article in the Journal of American Medical Association in 2000. So in it, they argued that narcotics dependence was comparable to diabetes, hypertension, and asthma in terms of its heritability, treatment adherence, and relapse rates. And as such, it should be treated as a chronic medical disease. So at the ASAM meeting, you're going to hear a lot of discourse about this, about really the cultural push to redefine addiction as a chronic disease, a brain disease. So the scientists involved in this movement had a clear social justice intent. They wanted to destigmatize addiction by demonstrating that it's a legitimate biological condition and not a problem of morality or choice. What they didn't anticipate was that their scientific universalism, because it implied a white male subject, would help to open white markets to new opioids, and that the unequal ways that biotechnologies are disseminated would enhance the social stratification of addiction. So what do I mean by that? For instance, brain images like this, by taking out the subject and his or her trappings of gender, race, and class out of the picture, and by taking the offending organ itself, the brain, out of the body altogether. The image symbolically conveys unmarked universality of addiction physiology. Neuroscientists further reduced causation to molecular action at neuroreceptors, which is the ultimate disembodiment of addiction. So the apparent universality of this molecular model implies an assumed white norm. It takes a problem long associated in the media and in policy with Black and brown crime and gives it a new implicit association with white people. In the process, however, it excludes social conditions. So the scientists wanted to counteract a drug war mentality by erasing the social context of drug use, but they paradoxically set the stage for a renewed racial stratification of opioids. Okay, so the next technology of whiteness, new biotechnologies. The neuroscientists that I just referred to unwittingly aided corporate strategists that capitalized on the erasure of the social. So building on neuroscientists' ideology of technological solutions to addiction, in 1996, Purdue Pharma got FDA approval for OxyContin as a minimally addictive opioid pain reliever. And this was based on its patented sustained release capsule technology, which in theory lowered the reward for users by preventing an initial rush, a rush of high concentration of opioids to the brain. The manufacturer influenced the National Joint Commission on Hospital Accreditation, JCO, to call for pain to be aggressively monitored and treated as a fifth vital sign, along with respiratory rate, blood pressure, pulse. And drug reps that were marketing the drug advised new opioid prescribers to direct OxyContin to quote unquote trustworthy patients, which in a national clinical workforce that has been shown to suspect non-white patients of drug abuse, this implied white patients. Of course, what the model of addiction-proof biotechnology left out was the social inventiveness of drug use. So OxyContin users who were interested in a rush quickly learned to crush and snort or inject the oxycodone in each capsule. After steep increases in opioid misuse and overdose, public pressure mounted for intervention, and in 2010, just as the original patent on OxyContin ran out, Purdue Pharma introduced its tamper-resistant time-release formulation, which embedded oxycodone into polymers that convert tablets into gummies should users attempt to crush and dissolve them so that they could inject them. By keeping prices high and representing OxyContin as technologically sealed off from misuse, the manufacturer strove to keep OxyContin symbolically a step ahead of urban, non-white street markets. Now, another biotechnology developed specifically in response to the white suburban and rural prescription opioid epidemic is buprenorphine itself, combined with opioid antagonist naloxone and branded Suboxone. So Reckitt Benckiser Pharma promoted this combination as a smart drug. Although buprenorphine is an abusable opioid, the naloxone with which it's combined causes withdrawal symptoms if it's injected, because naloxone cannot be dissolved under the tongue, which is the way that buprenorphine, Suboxone, is prescribed to be used, but it can be absorbed if you inject it, and it causes withdrawal. It's an opioid antagonist. So buprenorphine also posed a lower risk of overdose deaths than other opioids. And these things combined led NIDA to subsidize Suboxone's manufacture in the 1990s with $23 million to test it for use in addiction treatment, and sharply distinguished it from methadone, lobbying Congress and the DEA to lower the abuse potential rating of Suboxone from narcotics Schedule II, which is where OxyContin and methadone fall, to Schedule III, along with codeine cough syrup. So this is what made it possible to prescribe Suboxone in private doctors' offices. The manufacturer also lobbied Congress to get Suboxone included under an orphan drug clause designed to promote pharmaceutical development for unprofitable diseases in low-income countries, such as malaria drugs. Suboxone's designation as an orphan drug got it a patent extension through 2009 on a drug initially developed in the late 60s. So in a race and class stratified healthcare system, like we have in the United States, where access to general doctors is often limited to those who can pay, patented expensive technology designed for private office prescription in themselves encode white race and middle class. So this is the third technology of whiteness, regulation. Although by 2004, prescription opioids overtook heroin as the primary opiate of abuse in the US, the arrest rate for their illegal possession was 1/4 that for possession of heroin, and arrests for illegal sale of prescription drugs was less than 1/5 that of arrests for selling heroin. Not coincidentally, the non-medical use of pain relievers at the time was twice as high among white people as Black people, while rates of heroin use among Black, Latinx, and white Americans were almost identical. Since suburban and rural white opioid users were not politically popular targets for drug law enforcement, the DEA and other regulators focused surveillance and enforcement on prescription opioid prescribers and pharmacists instead. And one sign of this was the spread of prescription drug monitoring programs. All states now have some form of prescription drug monitoring, which mandate prescriber participation and often pharmacist participation with threats of loss of license or prosecution. So for example, in California, if I prescribe a narcotic without checking the database to see if that patient has been prescribed a narcotic by another doctor, then I can lose my license and actually be subject to charges. So returning to buprenorphine, otherwise known as Suboxone. The Drug Addiction Treatment Act that was passed by Congress in 2000, called DATA 2000, enabled any certified physician to prescribe Suboxone in the privacy of their own office. In congressional debates leading to passage of DATA 2000, there's a clear emphasis on a quote unquote new kind of drug user, one that's young, suburban, and quote unquote not hardcore. So that's implicitly white. And I just want to call attention to the coded racial language here. Recorded testimony from federal officials stressed that buprenorphine was uniquely appropriate for a new kind of opioid user as opposed to methadone, quote, which tends to concentrate in urban areas and is a poor fit for the suburban spread of narcotic addiction, end of quote. Then Health and Human Services Director Donna Shalala was but one of the many officials who noted that buprenorphine as an alternative to methadone would serve, quote, a new kind of addict, including citizens who would not normally be associated with the term addiction, end of quote. So with this racially coded language in which suburban and new kind of addict referred to middle-class white people, DATA 2000 passed Congress and reversed 80 years of federal prohibition of private physician opioid maintenance for opioid dependence. So DATA 2000 kept the restrictive methadone system intact and did nothing to alter the drug laws that mandated inner city heroin users to prison, but it did create a new treatment track for those with the resources to use it. To give additional assurance to the DEA that buprenorphine would not spill over into illicit markets, buprenorphine's manufacturer, along with the Federal Substance Abuse and Mental Health Services Administration, developed an 8-hour certification course that was required for doctors to prescribe buprenorphine. And this was the first and only prescription drug in the US to come with such a requirement. So for example, I as a psychiatrist can prescribe any kind of highly toxic chemotherapy with my license, but I have to get this certification in order to prescribe buprenorphine. And you'll hear some discussion at ASAM, I'm sure, about the effort to rescind the waiver. It was initially rescinded for a very brief period at the beginning of 2021, and then it was reinstated, the requirement, the training requirement. So public sector doctors tell me that the certification requirement is a major barrier to making buprenorphine available to low-income people because public clinics don't provide time or incentives to pursue this kind of certification. And in the private sector, doctors can charge fees of up to $1,000 for an initial half-hour buprenorphine induction visit. So there are doctors who have a lucrative practice around this in the private sector. The shortage of public sector prescribers, along with the cost of buprenorphine itself, have long kept buprenorphine in the private sector. And I want to highlight that JAMA 2019 article that I showed that documented that white Americans were far more likely to get buprenorphine than Black Americans. That same article also highlighted that the most common payment method was out of pocket for a very expensive medication. The second most common payment method was private insurance. And Medicaid, public insurance, was far down on the list. So that just shows you who's getting buprenorphine right now. All right, fourth technology of whiteness is ethnic marketing. OxyContin's legendary commercial success hinged on its designation as a minimally addictive opioid analgesic. When OxyContin was under review at the FDA, Purdue Pharma estimated its addictive potential to be less than 1% based on testing among terminally ill cancer patients for a 3-month period. In 1996, the FDA accepted this claim. They enabled Purdue to open a market for opioids that had previously been restricted to those with severe acute pain, like those with post-surgical or cancer pain. So what Purdue was able to do was open the market to a much larger group of patients with moderate chronic pain, such as lower back pain. They hired almost 700 drug reps to canvass a call list of nearly 100,000 physicians in the first couple of years. And these were generalists, largely generalists in white suburban and rural areas, serving patients that the public and the DEA did not think of as at high risk for addiction. So Purdue's strategy was successful. It led to a tenfold increase in prescription opioids nationally, with disproportionate uptake of OxyContin by prescribers in white suburban and rural areas of states like Maine, Ohio, Kentucky, and West Virginia. And this is where I get to my newspaper content analysis that I mentioned. I found that in contrast to articles about the criminality of Black and Latinx drug users, suburbanites addicted to OxyContin were portrayed very, very consistently in the media as victims of overprescription or people struggling with real or existential pain. It was remarkable how consistent this was, in contrast to the articles about Black and Latinx people with problem drug use that were described in terms of their criminal charges. Ironically, Purdue's technological response to the first wave of white prescription opioid overdose deaths, their tamper-resistant formulations of oxycodone, combined with the new prescription drug monitoring programs that I just mentioned, these two things led many of these opioid users to look for heroin when pills became harder to get. And one consequence of this was a whitening of the media coverage of heroin users who had long been portrayed as Black or brown. So this is a school teacher from upstate suburban New York, and this is a college athlete from Arizona. And they're just two images that I chose from myriad images around this time. This was about 2014, 2015. The targeted intervention for these new heroin users, buprenorphine, otherwise known as Suboxone, was marketed to middle-class insured patients over the internet with manufacturer-sponsored sites like this one. This is naabt.org. I invite you to look it up yourself. I invite you to read the race and class coding of the images that you see on this homepage. The web-based public service announcements on this page feature largely white professionals and business owners on Suboxone maintenance. This same website features a link to a Suboxone prescriber locator service that was created by the manufacturer along with the Substance Abuse and Mental Health Services Administration. So look in the lower left-hand side, patients find a buprenorphine physician. If you type in your zip code, you get a printout of buprenorphine certified prescribers in your area. The vast majority of whom are going to be in private practice. And these strategies together created an exclusive but highly lucrative segment of the market for Suboxone, making it a blockbuster drug at over $1.5 billion a year in US sales by 2012 alone, just in that year, second only to OxyContin, which reported US sales of $3 billion in 2012. So the manufacturer was able to get around a lot of political resistance to the introduction of private office opioid maintenance using this kind of racial imagery, and really did open up a lucrative market. So to conclude, this racial segmentation of drug markets into licit and illicit, white and Black, clinical and recreational, this creates a moving target of time-bound patents on new technologies targeting white middle-class consumers. And it's an old cycle. It was started by Bayer Pharmaceuticals' own heroin, which was marketed as a non-addictive treatment for morphine addiction among middle-class Victorian housewives in 1898. So I don't know if any of you knew the history of heroin, but it's fascinating to see how we've come full circle, in essence. And the other indication for heroin in 1898, when Bayer Pharmaceuticals, the makers of buffered aspirin, when they came out with heroin, they also marketed it as a highly effective cough suppressant for children. Just a very interesting fact. What can we learn from this as clinicians, researchers, and policymakers? One, I want to argue that magic bullets are a myth. And when I attend ASAM meetings, this is one of my primary messages to my colleagues in addiction medicine, because we're very much caught up right now in what is the next medication that will get rid of the overdose crisis. We're very much caught up in that kind of thinking. But as the failed promises of OxyContin's sustained release capsule and the inability of unilateral buprenorphine expansion to stem overdoses in this country has shown, biotechnology alone cannot stop the harms of narcotics without systemic and social intervention. And to underscore this point, I'm going to turn to an international comparison that many of my colleagues in the US who advocate buprenorphine expansion also point to, and that is France. So in France, where buprenorphine was adopted for general doctor treatment of opiate dependence in 1995, it was billed not as a stigma-reducing agent for a middle-class market, but as a public health intervention to stem overdose and HIV among low-income, largely immigrant heroin injectors. So as a result, buprenorphine was widely adopted among primary care doctors in poor communities in France, in a country, I just want to underscore, with universal health care. So in France, the overdose rate dropped 80% in the 5 years after buprenorphine's approval for general doctor treatment. And I want to contrast this with the US, where opioid overdoses are now 5 times, actually more than that after COVID, what they were when buprenorphine was approved in 2002. So this is a stark contrast. And based on my interviews with white and non-white people trying to access buprenorphine and stay on buprenorphine, I want to suggest that the public health potential of buprenorphine is limited by our race and class segregated, market-driven healthcare system in which patients have patchy insurance coverage and tenuous access to prescribers. So France has universal healthcare, that's a very important distinction to make, and a robust social safety net. And so, for example, in France, buprenorphine is often offered in community substance use treatment centers that are very comprehensive. They offer not only buprenorphine and methadone and other kinds of medical care, but they offer social services, help with housing, employment, a whole range of other needs, in addition to harm reduction measures. And so they combine medication options with, for example, safe injection facilities, and naloxone overdose prevention kits, and a host of social services. And these are critical elements to their success in France. The other thing I want to highlight is that if we go back to this slide, at 1995, you see in the upper left-hand corner, 565. That's the peak of overdose deaths in France. 565 represents 565 people who overdosed in a country of 60 million people. Contrast that with the US, where the number would be more like 565,000. So it's a whole order of magnitude lower. And one could argue France never had an overdose crisis. If you investigate further, you find that in France, all marketed pharmaceuticals have to be approved for use in France by an advisory board that's composed of people who do not have any pharmaceutical industry ties. So this is a very important distinction between the US and France, in that in France, OxyContin was never approved for the uses that it was approved for here. And in the US, of course, we've learned from media reports that those who sat on the FDA when OxyContin was approved quickly went on to take up leadership positions at Purdue Pharma and other opioid manufacturing companies.
Dr. Hansen, I just want to give a heads up on time. I want to make sure we get to some
Thank
questions.
Thank you for that reminder. So I'm just wrapping up. I just want to point out that we should be skeptical about the power of the market to protect the public and rectify inequalities in health, and that we need to think a lot about our for-profit healthcare system, how buprenorphine works in that system. I'm just going to walk through 2 other quick points. One is, if we take the metaphor that you'll hear a lot about from the ASAM conference this year, the metaphor that addiction is a medical disease, a brain disease, if we take that seriously, and the saying that I've heard a lot from my colleagues, that it's like asthma, diabetes, or hypertension. It's just like them in terms of being a chronic physiological disease. if we take that seriously, then we have to understand that successful treatment of asthma, diabetes, and hypertension also requires attention to the social drivers. So they're incredibly strongly determined by the social conditions that people live under. And we also should pay attention to the neuroscience of neuroplasticity, for example, and epigenetics, that there's this very strong relationship between social environment and biological response. And then the last point is we've heard a lot lately about deaths of despair, overdose as a sign of despair, social decline, economic decline in the US. But what we have to attend to, because deaths of despair was coined by the authors of this article that reported on decline in US white life expectancy, we have to attend to the racialization of despair as well. I gave you some of the statistics in the beginning about the steep increases in overdose among Black and brown people. If we go in to take, and I'd support this, I support really attending to socioeconomic conditions and economic development. So address the upstream fundamental drivers of overdose, but we must also attend to the racial justice issues, because without that, we're going to be reproducing the same health inequalities that we've had in every other area in US health. So I'll leave the other points. I'll just leave you up with those thoughts. The third one is about biosocial approaches to addiction, and we can talk about that in our discussion. But with that, I'd love to get your thoughts.
Okay, so let's, we have, we'll go to Stephen first. We have 17 minutes for questions, so let's get in many as we can. Stephen first, then Barbara.
All right, thank you, Doctor. I write for Modern Healthcare magazine. I was just curious as to what your thoughts were as to the likelihood that moving forward, if we come across a new drug crisis, addiction crisis with another type of drug, that we'll fall back into the same patterns of narratives in terms of considering it a moral failure as opposed to chronic disease.
So the question was how to avoid that, or?
Yeah, I'm sorry. Yeah, how do we? Yeah, moving forward, how does healthcare avoid falling into that same pattern that we've seen historically?
Yes. Okay. So you probably will hear at this conference a lot about the new generations of synthetic opioids, because one of the things that's driving overdose right now is the real surge in synthetic high potency opioids in the market, the illegal market. Some of which are so new, they're being manufactured in laboratories de novo, and they're so new that they're not even detectable using many of the drug testing approaches that we have now. So one of the big debates is there's kind of a new prohibitionism around having very heavy sanctions for people who manufacture and distribute these new high potency synthetic opioids that are really killing people quickly, often without their knowledge. So often people are sold one thing, and then the actual contents of the drug are these really high potency synthetic opioids. So we have a brand new prohibitionist kind of campaign going on that is happening at the same time that we're trying to adopt a more medicalized approach to addiction and really support buprenorphine expansion, primarily buprenorphine, secondarily methadone, and there's a racial story there too. Methadone is seen as a Black and brown drug. It hasn't gotten the same kind of attention, and disproportionately the people who do get opioid maintenance treatment who are Black and brown are still on methadone, and we can go into the details of why that is, but there are many different systemic factors leading to that. So right now the federal attention is really on buprenorphine, which has not solved the overdose crisis and will not. But I just want to highlight that this prohibitionist tendency coexists with a medicalizing tendency. One of the things that we're going to see, yet again, is the racialization and the class stratification. And when it comes to the discretion of judges on criminal charges around drug trafficking, also I want to highlight that that's a place where distinctions between who is a victim of drug traffic and just a simple user versus who is a pusher. This was Nixon's language, and it's The logic still carries through in our drug policies today. Judges have a lot of discretion, and there's lots of evidence that the people who will get sentenced under these new prohibitionist policies around high potency synthetic opioids are going to be Black and brown, because that will fit the pattern. So I guess a lot of my work here is to call attention to this as a racial justice issue, even as opioids 20 years ago were defined as a white problem. That we have to understand how drugs are racialized and how that plays out in our criminal justice system. And the fact that medicalization of addiction can happen simultaneously with criminalization in other areas, in other populations. So we now have this two-tiered system where we're heavily medicalizing for people who have access to private doctors, and they tend to be white and they tend to be better off. And we're still criminalizing for Black and brown. So you're raising a really good question. Well, what can we do about this? Well, I'm trying to, first of all, raise awareness. I'm trying to engage my colleagues who are doctors who have disproportionate symbolic capital to speak out on these issues and say, wait a minute, we think that we're doing a good job by promoting buprenorphine dissemination, but there's so much we're overlooking. And I'm also going around and educating and collaborating with my colleagues to get less of a simplistic brain disease definition of addiction out there, because if you only put out a simplistic message that addiction is a brain disease, and you don't attend to the social and systemic drivers of the patterns that we see, you're not going to have tools to intervene in a way that will create results that will improve population health. That's what we've seen over the past 20 years. That's why buprenorphine promotion has been a failure in the US. It's because we have not attended to the racial symbolism, the way that it's baked into our systems of healthcare and criminal justice. So that's the action that I'm taking, and I would love your suggestions on what other actions can be taken to make sure that we don't address the overdose crisis or substance use disorder simplistically as a brain disease. That in itself will not solve the problem. That will only perpetuate this two-tiered system. We have to attend to the social and systemic drivers. But I'd love to hear your thoughts too.
Okay, next question, Barbara.
Hi there, and thank you so much for your presentation today. I've been covering the opioid overdose problem for years. In fact, I went to a safe injection site in Montreal, a few of them, a year and a half ago. I guess my question is, you go back to a lot. I've been to a few ASAM conferences. People there, doctors there are not on the same page. Absolutely not. It can be confusing to those of us who cover this. How should we be characterizing opioid use disorder? What are best treatments? Are the messages we need to be getting out there? And how do we get more people on the same page? So I'm putting some questions back at you.
So when you say that at ASAM meetings, people are not on the same page, do you mean that you're hearing a diversity among ASAM members?
Yes.
Okay. So actually, I think that in itself is kind of a good thing, in that, I'd be interested to hear what's the range of the diverse perspectives there. But let's face it, you're not going to get anywhere by oversimplifying this problem. I mean, that's kind of the message that I was trying to get across in my answer to the last question, that this is not a single solution kind of problem, right? And it's very important to get that message out there. So the fact that there are ASAM members who may not be quite as focused on buprenorphine expansion, that might be focused hopefully on things like safe injection facilities, hopefully on, well, how can we bring in social and economic development and social services? How can we address this as a social problem, not just a physiological or brain disease problem? How can we attend to racial justice in drug policy more broadly? How can we use the overdose crisis and its real purchase right now in combination with COVID? Because COVID and the overdose crisis they've greatly exacerbated each other in terms of death rates. They have followed the lines of a lot of race and class inequality, and so we now are in a moment where we're attending to race and class inequality and how much that flies in the face of public health promotion. We actually need several different levels of intervention. And so what I would hope is that my ASAM colleagues would build on the strength of diversity and getting out the message that this is not a single solution problem, and that we do need to have addiction medicine advocating for attention to all these different levels. So not just let's develop and market new medications, which is where I see a lot of our federal energies going. You know, over the past decade, NIDA, for example, has invested a tremendous amount in public-private partnerships with pharmaceutical industries to develop new medications for addiction. And they've really neglected, vastly underinvested in comparison to these public-private partnerships with pharma for drug development, vastly underinvested in social services, in developing the healthcare system to make it accessible. That has not been there. So what I would love for ASAM to do is to assign various members that have expertise in these various areas to addressing it as a multifactorial, multi-solution problem. That's really what we need. I hope that answers your question.
Okay, so we have 8 minutes. I got 5 hands up, so try to think in terms of the short 60-second answer, so we can hopefully get all of them in. We have Kyle, Camelot, Adriana, Madeline, and Miri. We'll go to Kyle first.
Thanks for making time for us, Doctor. I want to ask you, because it seems like, those of us who have worked in local media, and I'm with Gray Television's DC Bureau, have heard the double-edged sword of, don't report on an especially deadly form of fentanyl that might be out there or heroin that might be out there, because that might actually be an advertisement for users to go out and get it. And I'm getting kind of the same sense when it comes to portraying race in covering these issues. And so I'm wondering, what suggestions you might have for how to do that without falling into the pratfalls, whether it be portraying a drug as one race's issue or being colorblind and thus the assumed whiteness problem.
That's a great question. So I'll answer the second part of it first. The question about whether to report on what's in the market, that's a fascinating one. I hope we have time for. So the second thing, how to report on race and drug use. I think that's such a great question and a sensitive one, because we're coming off of a century or more of very strong linkage of Black and brown faces to drug use in a way that flew in the face of the actual findings around who was using drugs. Because it hasn't been at all confined to Black and brown people. And in fact, one of my co-authors, David Hirschberg, who's a drug historian, has shown that the drug crises of the past, including heroin, have started off with white use. The consistent pattern is that white users have started these trends, often better off white people with the resources to get them. They've started a drug use trend that has later trickled down, so to speak, to lower income Black and brown people. And so the whole image of Black and brown people as introducing or pushing new dangerous drugs is actually the opposite of what historians and epidemiologists have been finding. But your coverage of it is very important. So I would say it is important to report on the fact that Black Americans are now really quickly rising in terms of overdose rates and overtaking white Americans in many places. That's crucially important, but it's important to report it in a way that contextualizes it. So in other words, to give the history, I tried in the time we've had together to kind of paint a portrait of the contemporary history of opioids, what led us to this point, and the way that race is implicated in that, and racial imagery. I know you don't have space in all of your reporting to give that kind of history, but definitely to contextualize the problem so that it's not left up to the reader to imagine that there's something about either the culture of poverty of Black and brown people or the genetics of Black and brown people that could lead to this dramatic rise, that this is coming on the heels of a whole context of drug use that predisposes people due to poverty, due to over marketing, very aggressive marketing in their areas. That was true for whites, that's now true for Blacks. And so I just invite you to give a more nuanced explanation for the racial patterns that you're reporting on, rather than simply reporting and then leaving it up to the popular imagination, which has already been primed to think in terms of moral deficit or biological deficit.
Thank you.
Okay, next question to Camelot.
Hi, I'm Camelot Todd. I cover mental and behavioral health for Western New York. My question is, how do you address the racial and social economic, factors into addiction at the policy level? So it's great that we're introducing new medications and a new way of thinking of addiction, but without addressing, poverty, housing stability. How do you fix that so that you can provide that stability for recovery?
Well, thank you. That's a big question. How to stimulate equitable economic development in the U.S. That's a huge nut to crack. And I, as an addiction psychiatrist, anthropologist, I may not be able to give you the answer right now, but I think the important thing is to call attention to overdose as just one of the myriad signs and outcomes of our need, our desperate need for that kind of economic development. And I'm glad to see right now that the national discourse seems to be heading in that direction, that we have to figure out a way to reinvent our economy with a lot of potential to racial equity. So I would say just making sure to, characterize the overdose crisis as just one more sign that that's the direction that we need to go in. And then you as a reporter, I'm sure will be tracking what policy experts are doing to develop an agenda around that, because that's desperately important. And one thing in the US that I find I'm often doing, I did the comparison with France. We in the US don't pay a lot of attention to what other countries are doing, particularly in the area of healthcare, that's more successful than what we do. And it's always shocking when I'm teaching medical residents and students and my colleagues for me to introduce this finding from the National Academies of Medicine that the US spends the most per capita on healthcare and gets the worst results of any industrialized nation. Why is that? And a lot of it has to do with our very broken profit-driven healthcare system and the fact that we lack public health-oriented laws around things that drive health outcomes, such as housing, such as gun control, a whole list of things. And so I would say it's important to place overdose in the context of a whole other lot of indicators that our society is not organized around public health promotion, and that what we need is a new national and local agenda that is focused on health promotion. And that includes economic development and racial equity.
All right, Adriana.
Hi, I'm a health policy reporter for Yahoo Finance. My question, I noticed when you were showing, I think it was two charts, it was figure B, it showed the difference between private insurance, self-pay, Medicaid, Medicare, in terms of like how they can get the medication-assisted treatment. So just, sorry for the sirens, does Medicare and Medicaid, do they not cover it as much as private insurance? And I guess it's a two-pronged question because I want to know, does that make it into a class issue as well? People who can't afford it can't get the treatment?
Absolutely. So the answer to the second question is very easy. It's definitely a class issue. It reflects, again, the whole makeup of our healthcare system. We have a healthcare system that's very race and class exclusive. It's a privatized healthcare system for the most part. Medicaid does cover buprenorphine. What Medicaid does not do is adequately reimburse buprenorphine prescribers and ensure that there are certified buprenorphine prescribers available in the public sector. So that's the major barrier in the United States. And I just attempted to give you essentially a history of why that is, that there are several different systemic factors that are all converging to ensure that buprenorphine is not a public sector kind of a drug. One of the reasons that the manufacturer was able to get legalized the private office prescription of buprenorphine, which was a huge coup. This was a big, big development in drug policy. They got around a tremendous amount of resistance from the DEA and prohibitionist drug policy because essentially it was marketed as a white middle-class drug. These are trustworthy people. These are people who are not going to abuse the buprenorphine. So they used race and class imagery to get around those policy barriers. We're now seeing the next generation. We're now seeing an effort to get buprenorphine into the public sector. But the reason it's 20 years later is that this was a drug that was specifically developed as a white middle-class drug for the very reasons that to get over those policy barriers. So we're now at a moment where buprenorphine advocates, expansion advocates, are trying to systemically retool the way that buprenorphine is disseminated so that it can get into the public sector. But it's not a mistake that they've had to do that.
Okay, so it's 8:30 your time. Do you have to bolt now, or do you have time for another question or two?
So I have a couple more minutes. I know that I'm cutting into your break time, so I don't want to take up too much of your time, but if you'd like to talk for a couple more minutes.
Yeah, I mean, if we can grab the final two questions, they'll still have a 10-minute break. And I'd rather get the questions in, I guess. So we'll go to Madeline and then Miri, and then that'll be it. So Madeline first.
Great. Hi. Thank you so much. I'm Madeline Beck with the Mountain West News Bureau. I report for NPR stations in the Intermountain West. I was just wondering if you could talk about the distribution of naloxone and Narcan versus the distribution of things like methadone and buprenorphine in these areas, because I guess seemingly from the outside, and please correct me if I'm wrong, we've been so much more successful at getting naloxone to regular people than we have these longer term solutions.
Yes, I would agree with you. I think that naloxone is an easier sell. You know, it's kind of low hanging fruit, and there are a number of places where there have been inroads in making naloxone overdose reversal kits available in pharmacies without prescription. So you can, anyone can just go in and get them. There's a campaign, you'll probably hear about it at ASAM, a campaign to give naloxone kits to significant others for anyone who comes in for a visit. So that's been low hanging fruit for the most part. And where you'll find a lot more resistance is, for example, the idea of safe injection facilities as a harm reduction method. So, there's a range in terms of political resistance to harm reduction, and safe injection facilities, which are now by many of my colleagues called medically supervised opioid prevention sites, because it turns out when you rename them in that way, medically supervised opioid prevention sites, all of a sudden they get a lot more public support. So even the naming of it is very important. In Canada, they've made many more inroads with this. And it's fascinating to see they have a lot of accumulated evidence in Canada that it lowers overdose rates, not just for people who visit the sites, but overdose rates in the neighborhoods in which they're located, and even reduce crime rates. They've been tracking things like that. But those studies really haven't gotten purchased in the United States. So back to this theme of we're not paying attention. We have a political system that prevents us from gathering this kind of evidence here. We need to attend much more to what we can learn from other countries. And in Canada, they're now implementing safe supply measures. And COVID really helped to accelerate that process, where pharmacists can provide pharmaceutical grade narcotics for people who have physiological dependence. And that prevents people from going on the illegal market to get things that are laced with fentanyl and other non-detectable high potency opioids. So, there's a whole range in harm reduction and political resistance. But I do acknowledge that naloxone is probably our entry point. Most people can agree on that, and hopefully we can build from there.
Gotcha. Thank you so much.
All right, final question, Miri, as long as it's a fairly short question and a fairly short answer.
Yeah, so my question was about how do Asian Americans fit into all of this? So, is there an overdose crisis in the Asian American community? Does it fall on one side or the other in terms of, the methadone versus Suboxone issue? And, how are things portrayed in the media, like if at all?
What a great question, because I think I opened with an image of Chinese opium dens, a century ago. And so Asian Americans have been implicated in drug policy from the very beginning. I think one reason why Asian Americans have not gotten a lot of attention in the opioid crisis coverage is that if you take the kind of artificial category of Asian Americans, artificial in the sense that you're lumping together people from tremendously different countries of origin in terms of their ancestry, and tremendously different profiles in terms of migrant status, socioeconomic status, educational level. I'll take New York City for an example. These things, problem drug use and consequences in terms of incarceration, overdose, they tend to group among lower income Asian American groups. So for instance, in New York City, South Asian groups such as Bangladeshi people who have very low socioeconomic status, they tend also to have many of the profiles in terms of public problem drug use. if you lump everyone together, then you're also including a whole host of people who, for whatever reason, have not been caught up in this current opioid crisis. And so if you group everyone together, the statistics are going to look as though Asian American opioid overdose and problem opioid use are very low, that the rates are low. But we shouldn't stop there. I have colleagues who are investigating what's happening with different subgroups in different neighborhoods of different socioeconomic statuses. And we find similar stratification as we find when we compare, for example, white Americans, Native Americans, Black Americans, Latinx. So it's a great question. And we simply need much more attention to Asian American health, including when it comes to opioid problems.
Great, thank you so
and with
much.
that, we need to, excuse me, draw this session to a close. Dr. Hansen, thank you very much.